Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, December 10th, 2024, we are speaking with Dr. Kevin Carmichael. Dr. Carmichael is a family physician who began work in HIV in 1983 while in medical school in Miami, Florida. During his residency at the University of Miami, Kevin co-authored one of the first written guidance books for HIV clinical care entitled HIV AIDS, a Primary Care Handbook. He was a founding board member of both the HIV Medicine Association and the Ryan White Medical Providers Coalition, and he currently works for the Arizona Department of Health Services Office of HIV and Hepatitis C Services. Today, Dr. Carmichael joins us to talk about how far we've come with HIV. Kevin, welcome to the podcast.
Thanks, Mike. I'm happy to be here.
Well, it's really great to have you, and we've known each other for maybe almost 40 years now, and it's hard to believe, but one of the things that I'm sure you've noticed is that not just the incredible progress we've had, but that the majority of HIV physicians and providers that I work with weren't even born in the 1980s. Most of them did not experience the AIDS epidemic at the beginning. And so what I'd like to capture over the next 25 minutes or so is just a flashback to what it was like in order to help set the stage and provide a foundation for a lot of the providers who are currently working in the field but really don't know what things were like back in the bad days, if you will. So let's just get started. In general, you've first started seeing patients with HIV at the University of Miami, and you were a medical student. Can you recall your first patient?
Yeah, when I first started medical school, I remember one of the first special noon lecture was about GRID, gay-related immune deficiency, by one of the pathologists spoke about it. But of course, you really don't have, and so I was interested because I'd had friends in college who were gay, and it was also something new. You're in medical school, it's new, no one knows what's going on. It was really interesting. But you really don't have patients till you're a third year student. And my first rotation as a third year was internal medicine, and my first patient that I took care of was a young woman from Haiti who had AIDS. Of course, at the time, we really didn't exactly know everything that was going on, and she died in the course of 3 days. Um, she did not speak English much at all. I came from a background of, family medicine, which we will talk about maybe a little bit more later. But, I held her hand, I sat with her, I didn't know what was going on, and 3 days later she was dead. So
That's
that was my introduction.
that's pretty powerful, and obviously that stays with you. What did you think at the time? What was going through your head as this all kind of exploded in your face in a way?
Well, I think as a medical student, it was hard to really put it in a huge context. I don't know that I ever thought that, decades later I'd be talking about that particular episode. Um, but it was powerful. And again, I had friends who were potentially at risk. And so it really did resonate in lots of ways for us.
In the early 1980s, Miami was one of the epicenter uh, large cities, along with New York, San Francisco, Los Angeles, Atlanta, Dallas, perhaps, Houston. And those cities really were catching the brunt of this. So imagine over the next several years of your residency, you saw many more patients with HIV. Collectively, by the time you finished the program, um, how did this all come together in your head and sort of guide you to start working in the field?
Well, so you're right. I mean, and I think mine was a little different in the fact that we had this Haitian population, which is maybe a little bit more expansive than just men who have sex with men, what we saw
Could
in
you
other
speak
cities.
Creole? Could you communicate?
I could deliver a baby in Creole, but some of the subtleties were definitely hard to get at. But we did have some faculty in the family medicine department from Haiti, and it was interesting. Um, but I think, again, it grew, as you're right, and lots of people got involved. University of Miami, Margaret Fishel um, I guess, a little bit of a role model for me. I mean,
Mhm.
for those who don't know, she published along with Tolvoberding the first paper. Zidovudine as a treatment for HIV. And then Gwendolyn Scott in pediatrics and Mary Jo Sullivan and OB. So it was every rotation that you did, and as a student and as a resident, you were running into people with HIV. So it was sort of inescapable. Um, but on the other hand, I didn't think I really considered myself that was all I was doing.
Yeah. At the VA, you had Gordon Dickinson and
Gordon
right.
Dickinson. Oh,
So
yeah,
it's a
yeah.
good group of people there. Um,
Hmm.
but one of the things about Margaret Fishel in particular is that at most places, it was either some subspecialty that was engaging. It was either hem-onc, because of the lymphadenopathy, like Donald Abrams in San Francisco or others, or it was infectious diseases. But Margaret was an internal medicine specialist. She had no further development, and yet she grabbed the bull by the horns and really established the outpatient clinic at University of Miami and set up a lot of the clinical trials, including, as you mentioned, the first AZT study. Were you sending patients to that trial?
Yeah, actually, there was well, a couple things. I mean, Margaret Fishel was, I think has gotten some flack from the HIV community over the years. I think you remember some of the early days when people were angry, upset about AZT not being as good as we had hoped it was. But on the other hand, I remember very early going to meetings, community meetings with Margaret, meeting with the community, with people impacted, affected, and I think she deserved a lot of credit for that. And I think that's a lesson I learned early on, how important that was. And yeah, there was actually someone who became a good friend, a woman named Bonnie, a nurse who used to come around on the wards and sort of recruit people for studies. And so yeah, we were definitely involved with them quite a bit.
So, but again, going back to the question of your decision to take this on as a family medicine physician, um, and run with it, it had to be motivated, I would guess, by your collective experience of taking care of a fair number of people, Haitian or otherwise.
Yeah, just to be clear, my father was the chairman of the Department of Family Medicine at University of Miami. He started the first residency in family medicine, and so I actually was pretty steeped in some of the the philosophy of family medicine. And family medicine started from a pretty radical place. And some of his faculty were gay, and uh, we were also very involved with the community health centers who were actually seeing people with HIV without a whole lot of experience or knowledge. And one of the things that we did early on in the Department of Family Medicine was I actually liaised with one of the community health centers, and we had other faculty, one for each community health center, to help them coordinate with the Jackson Memorial, the county hospital, university hospital, to get people seen, to get studies done, and things like that. And that's actually where the whole idea of a handbook for HIV care came from.
So, those who aren't familiar with the geography of South Florida, there's Dade County, which is Miami, and Jackson is the county hospital and serves the general area. And then just to the north is Broward County, where Fort Lauderdale is, and they were getting hit hard too. How many patients were you seeing at Jackson that were coming from the surrounding area versus local cases?
I I'm not sure I really have a good answer for you there, Mike, because we were, people. Jackson was sort of the hospital of last resort, but it was also sort of the um, the hospital last resort, but also the university hospital. And so I think there was definitely, I mean, again, the stigma around HIV, was present everywhere. And in Miami too, not every provider, not every faculty member, not every student, not everybody there was comfortable or interested in taking care of people with HIV. Um, but there were certainly a lot that were.
Let me dig a little deeper into your relationship with your dad on this topic. So, obviously, he's, I'm sure, supportive of you, but what was his feeling about what was going on and your ultimate decision to commit to this path?
Well, it's interesting. Again, I sort of didn't realize that I was committing to this path really until I got to Tucson. I had written a book with my sister. My sister and I wrote a book, a handbook. Actually, I actually looked and found uh, one of the first editions from 1990. I think it was the second edition. It's 17 pages long. There's one antiviral in it. Um, and then eventually we ended up, with Margaret Fishel joined us, and we came out with a more complete handbook. Although this handbook only has 4 drugs in it, and they're all nucleoside reverse transcriptase inhibitors.
Yeah.
So I think it really felt it. But back to the question of family medicine, I mean, family medicine is about being with the patient where the patient is, and so it certainly fit. The family medicine department taught sexual health in the medical school, so it was a natural fit. For us. And again, supporting the community health centers was another important part of family medicine from the academic perspective. So it really was a natural fit. And later on, though, in as he retired in Tucson, one day I was talking to him after I was done working, and my father was also in Korea, worked in a MASH, in a hospital in Korea, and he was like, "Gosh, this reminds me of Korea, because I was
Mm.
having so many people passing and so much trauma and craziness."
Wow. So I'm putting two and two together here. It sounds like your dad got recruited to the University of Arizona Medical Center from Miami, and that's
Oh, no, no, he retired to Arizona
okay. So
because we were here.
how'd you get to Tucson?
So that's a long story, but I'll try and make it quick. Basically, my wife did her family medicine residency here, and so I said, okay, we're going there, and we were into rock climbing at the time, and Tucson had a great rock climbing. So away we came. I took a position as a fellow in academic family medicine, and there was actually a family practitioner in the fellowship the year before me, Bruce Williams, who you may remember, who ended
Mhm.
up in New Mexico running their HIV program, and he had assembled a panel of HIV patients in the family medicine clinic. And then I had already written my handbook, and so I came in and sort of took on his patients and went on from there.
What was the scene like when you arrived in terms of numbers of patients and types of patients? I suspect not many Haitians at that
No,
location.
it felt a little bit like going backwards in time in the sense that the numbers were smaller. Uh, but but again, there were great people here at the University of Arizona doing work. They had an immune deficiency clinic, doing some research. Um, and the bigger thing I think though is quickly Dr. Eskil Peterson was the head of infectious disease, and he was very encouraging. And I became involved with the community, with the People with AIDS Coalition of Tucson, the Tucson AIDS Project, things like that. And then the community health center in Tucson, El Rio Community Health Center, got funded in the first round of Ryan White funding, and I ended up moving over there to build their HIV program.
So the time, just to orient everyone, it sounds like you moved to Tucson in the mid to late 80s, and then 1991 or two was the Ron White Care Act.
Right. I think we got here actually in 1990 and
Oh, you
91.
did.
I think was when 91 is when I moved over to El Rio. And that was a little bit scary because I left the university hospital. I was at a community health center. I was next door to a Catholic hospital, community hospital, a little worried how they were going to accept it. And they were fabulous. They were
Yeah.
wonderful.
And you can't predict that, can you? That was the thing I think for everyone to orient to this. Um, every community was unique, had its own set of challenges based on attitudes, mainly of the hospital administrators, the leading physicians in the community. And as you indicated, this in sort of contrast to Miami and New York and San Francisco, smaller communities, and Birmingham, Alabama would be one. The epidemic came sort of crested a little bit later, and in our case, just curious about yours, it was people coming home. They had been living in some of the epicenters, and then they got sicker, and friends just couldn't provide the care. So they came home to families, and they would be scattered, perhaps in Birmingham, but around the state. And the docs in the local area either didn't feel comfortable, didn't feel like they had the knowledge, or had antipathy in some cases towards taking care of patients with HIV. Was that the scene in Tucson? Was it similar to that?
Yeah, I think that's exactly the case. People were coming back here to be with their families. We did have people coming across from Mexico who were sick and needed care. It was sort of all hands on deck, who could be there and provide support. We
So,
saw very few children, but you know.
and that's one advantage that you had as a family doc, that you took care of both children and adults, I assume.
Yeah, actually, I got a little bit of trouble over that because I was still at the university, and of course, someone asked me if I would see a child, and I said of course, and I hadn't come to the internal medicine clinic, which was a major faux pas, and I didn't involve the pediatric infectious disease people out of my naivete, and actually they really did develop a fairly, if small, but a very good pediatric ID program for people with HIV at the University of Arizona. So I certainly made a lot of mistakes along the way. Uh, sort of more out of just trying to get people taken care of. Like we got to take care of people.
Right. So you're now into the early 90s. The only drugs we have available mostly are AZT and the D drugs, DDI, D4T,
Yeah,
DDC, which
yeah.
we,
Don't forget DDC.
yeah, boy, and what we're sort of focusing on, I'm sure, are the side effects, which include pretty profound neuropathy. AZT was mostly nausea, vomiting, GI, muscle wasting, and occasionally with all of these, lactic acidosis syndrome, where the liver turns basically to fat and it can't clear lactate anymore. It becomes a fatal condition for a lot of folks. So tell me just one of your stories of the bad days of a patient you took care of who really, um, you connected with, and had to watch go through the throes of advanced AIDS where you had very little to offer.
Yeah. Again, for the when I joined El Rio, I was the HIV doc. I was the only one, and we grew to having lots of, but I think 5 or 6 providers by the time we ended there. But so I took care of people in the hospital as well. We would hospitalize them at St. Mary's. There was one of my first patients was a nurse who had CNS lymphoma, and he got sick and died very quickly. But he was a nurse at Carondelet Hospital, at the hospital, St. Mary's Hospital, where I was, and everybody loved him. And I took care of him, and it kind of made it very easy for me to be at that hospital afterwards because everybody was so appreciative of what I had done. In fact, the floor that he worked on asked if they could bring all the HIV patients to their floor. So I actually had sort of my own little floor. It was not all my patients, but the nurses there wanted to have our patients. And so it really was a good thing. But oh man, the stories you can go on forever. I remember Carondelet, actually, St. Mary's had a hospice across the street, and I had patient in hospice, and he had was an artist. He had lots of friends. They're all with him. They said, "Can we take him outside?" He was very near the end of life. And I said, "Sure." It was a beautiful Tucson day. Sun was going down. They took him outside, and I go outside to see him, and his bed's out there, and he dies right there. And then a car drives by, and it's the parents of another patient who's in hospice, and they sort of are looking at me, and I'm there, and everyone's crying and hugging, and then I go into hospice to talk to this family. I mean, there's the stories, just you go on and on and on. I mean, you can't stop them, I think. Yeah.
Yeah, I think those are good examples of what it was like. I mean, for me personally, I remember I deliberately chose not to go into pediatrics, not because I didn't like kids, but it tore me apart too much to see children dying and then dealing with their parents. And ironically, as I got into HIV, the patients were in their 20s, 30s, maybe early 40s. They were dying, but the parents were involved. So, ironically, I ended up taking care of a lot of kids, if you will. They just were older who died and dealing with the parents. And for me, dealing with the moms was especially challenging in a sort of heartfelt way, but um, they just never gave up on their sons or daughters, but mostly sons. And for the sons who were gay, it often meant coming out for the first time as they got sicker, and the fear of being rejected from their parents. And that was a big deal. It was a universal theme that we dealt with all the time. And I'm sure you had similar experience.
I remember one guy in the ICU, and he did not want his family to know. And so you're taking care of someone who's dying, and you really can't tell his family what's going on. And that was really hard to provide support and care for the family, because that's part of our job. And then, honoring the patient's wishes. And that was challenged. I did have one patient, and he said he was very worried about telling his brother. And I said, look, your brother loves you. If he doesn't support you, then the heck with him. I think I used some other words, but the heck with him. And then one day he came in, he said, hey, I told my brother, I remember what you told me. If he did rejected me, the heck with him. And I said that, and he said, yeah, that's what you said. And I said, oh, okay. And I said, what happened? He said, oh, he loves me. He's taking, and he was just so relieved, you know. So I think there was, it was an interesting time, because at the beginning of HIV, being gay was tough. And I think part of the thing about HIV is that everybody was sort of outed, and then people realized that nobody was not impacted at some level in their family, their friends, the people they know. It was a hard thing, but I think there was something gained by that. I wish those lessons people still remember.
Another common theme that I encountered is a classic story of a similar type of patient who did not want to tell family, and I convinced him that he should tell his mom. So he said, would you be there? And I said, sure. So we bring mom in the room, and it's the three of us. And, in a very tortured way, the patient says, Mom, I want you to know I'm gay. And the mom goes, you don't think I knew that?
Yeah.
I'd known that since you were 4 years old.
Yeah.
And I just thought of the tragedy of these two people living in parallel, neither one wanting to bring up the topic. And so it was a really fabulous healing moment for both of them, and enabled them to sort of embrace and put that behind them. And even dad got involved, and they're usually more stoic and less emotive, if you will. But there was a lot of precious moments, I'll call it, where it made it really the essence of what we do as um, primary care docs, and as people that take care of folks in difficult situations.
Yeah, and those were the sad but good stories. But there's some bad stories too. I once had a patient. He was living a mobile home out, and his family was coming to visit from the Midwest. And I said, okay, when I finish my clinic, I'll come over and meet with your family. So I drove over there about 6 o'clock. I got there. He was there on the sofa. There was nobody there. I said, what happened? He said, oh, they already left. And then I looked around, and they'd taken his TV, they'd taken all his stuff and just left. And so, for the good stories, there were good stories, but there was also some tragedies. But again, the community, I think, the larger community, at least in Tucson, and I think everywhere, communities pulled together to support people like that.
Right. And the fact that our treatments, there were some that was better than nothing, I suppose, but they started failing after 12 to 18 months of treatment, be it with any of the nucleosides. And then they might have a little bit of a reprieve for, again, a year or so, a little bit, and then they'd start getting sick again. And the desperation among the patients, clamoring for something new. And then finally, it starts to happen. And I just wanted to bring up for you Tucson 1995. Tell
Yeah,
us
just
about.
before we get to 95 though, you're right. Remember SPV 30,
Yeah,
all these other things that came from other sources, from homeopaths or alternative people and all that. And I tried to, I couldn't necessarily endorse those things, but I didn't take those things away from people. It was a very interesting time. People were trying all kinds of things. But 1995, yeah, the first patient I put on a protease inhibitor, I actually used sequinavir, because that's what I could get. Remember, it was an expanded access. Late 1995, patient from actually from southern Arizona had MAC, had a draining lymph node that had been surgeon had IND'd it and never cultured it for AFB, and then I got to him, had MAC, got him on that drug, and the line was so sharp between people. So for my clinic in 1995, I had 76 people die in 52 weeks. In the first half of 1996, I had, half of seven. It was exactly like 95, but the second half, the death rate in 95 was 14 deaths per 100 patients in the clinic. And 96 was that transition year. In the first half, it was that way. The second half, it was 2 deaths per 100. In 1997, I was down to 2 deaths per 100 patients, and it went down. And the line was so sharp. There were people I knew. One of the people I knew, I was not his doctor, but he worked in the AIDS service organization, community organization, and I was very aggressive in trying to get protease inhibitors, even sequinavir, which, in retrospect was probably not the greatest drug, but you couldn't access anything else. I couldn't access indinavir initially because it was only available from one pharmacy in Pittsburgh. And, but, and I think back to that guy, I loved him. And I think sometimes I feel like if I had been his doctor, maybe he'd still be alive today, because I might have got him on a protease inhibitor a week or two, just enough, and I think that's something that's just incredible, how sharp that line. I don't know if you had that same experience, but that line was so sharp.
I did, and what I communicate is a lot of people have experienced the Vietnam Memorial on the Washington Mall, and if you recall, you walk into it and you just slowly get deeper and deeper and deeper until this thing is so overwhelming that you're in this almost pit, and then you pivot 90 degrees and you see sunshine and the Washington Monument, and then you start to emerge from that. And that's, to me, a great metaphor for what it was like taking care of AIDS patients. We got deeper and deeper and having virtually nothing. And then that moment happens when the triple drug therapy, the what we call heart highly active antiretroviral therapy hits. And you've described it very nicely in terms of numbers, but it was palpable, because not only did they live, they suddenly had appetite and their skin rashes went away and they had energy, and they were like, it's like you waved a wand and all the color returned to Pepperland, if you think back to the Yellow Submarine movie.
Yeah.
And that's kind of what it was like. So where were you when when it first dawned on you, holy shit, this is actually a game changer?
I mean, I was in Tucson going to work every day at my clinic trying to take care of people. And you're right. It was unbelievable because, you know, the number of people we had in the hospital started to decline, not quite that quickly, but it started to decline. Everything changed. And then it became an issue of getting people, accessing the meds, getting people to stay on the drugs, and those issues, which are still issues for us today.
Sure, sure. But I guess what I'm asking is, you obviously heard about the Indinavir triple combinations or
Sure.
some of the others. Do you remember when that information came to you and when you discovered this?
Well, I think I mean, it was mid 1995, really. The data was starting to emerge and sequinavir became available on expanded access. And it was like, I have to get this drug for my people,
Yeah, yeah,
I'm going to get this drug. What do I have to do to get it? And, that's when, and it became clear. And again, you're not practicing in a vacuum. People around the country, you look at the studies, you read the studies, you talk to people, and everybody, I think nobody believed it at first. We were all a little bit, we were burned a little bit by AZT because we thought, oh, we got a drug, it's going to help. And then it didn't, as much as we wanted.
What I remember most is Croy, 1996.
Mhm.
Emilio Amini talked about triple therapy
Right.
with Indinavir from Merck. And the data were presented, and I was sitting up in the balcony at the Sheraton Hotel in Washington because I knew the data. We had actually been participating with
Sure.
Indinavir since we did the first phase 1 study with the drug, so I was very familiar with it. And I looked, and the audience was stunned. They didn't quite know what to say or think. And then about 4 months later, 3 months later, we're in Vancouver, Canada for the 1996 World AIDS meeting, the IAS meeting.
Right.
The exact same data gets presented, and all of a sudden, it's like everybody suddenly comprehended what this meant. So
Yeah.
they saw the data, a lot of them in March, and by July, they hadn't either enough time to process or they were receptive. And that to me was kind of the turning points. That's when the light came on and things
Yeah.
changed so dramatically.
Yeah, absolutely. I mean, it is. I mean, you sort of didn't want to believe it. It's like you didn't want to believe it because you didn't want to get your hopes dashed. But then it became so clear and so obvious, and it really, it's just remarkable. And again, it's remarkable. But sometimes I look back thinking, shoot, if we could have just got some more people on sooner, they'd still be
Mm.
here today.
Yeah.
I mean, that's really how fine a line it was. Think about people who lost their partners and all that stuff. And it's like, and so it's definitely a good thing. But I do remember a few years later, in fact, I think you were the one that was in Newsweek magazine that maybe the death rates are starting to go up. We saw, because I mean, again, the problem with the protease inhibitors were that they were good, they were great, but they weren't as great as we want. And people were starting to develop, accumulate resistance mutations. And we'd see people with detectable viremia and all that. And there was a little tick up there. I had the same thing in my practice. Is it maybe 2 years later, was it?
Yeah.
A
About
little tick up
97,
in,
98.
yeah,
Yeah.
a little tick up in deaths, and then it went back down, and really had done pretty well ever since.
And ever since the integrase inhibitors, it's
Yeah,
assuming people can take the medicine, it's pretty
yeah,
miraculous. So,
yeah,
Kevin, the time has flown by.
yeah.
We're really kind of at the end of our time, but you captured exactly what I hoped we would, and that is a flashback to the days before that transition point, that turning point, the inflection, where we went from a death sentence in most people to a chronic manageable condition, and that really happened in the year '96, with a lot of the research going on between '93 and '96. So now we're in 2025 almost, and the IAS-USA has their latest guidelines out, and it's really fine tuning the use of antiretroviral therapy, and a lot of focus on managing internal medicine issues like cardiovascular outcomes and weight gain, but also pre-exposure prophylaxis and new options there. What's your message to younger people who are living in this platinum age, I'll call it, of HIV care, um, and what would you like them to take away from the past and use it for their practice in the future?
Well, I think there's a lot of lessons there. I think um, the first thing is I think it's good to know what happened, and I like to talk about that. I actually have a little slide deck I show stories about it because so many people don't realize what happened. On the other hand, I think that the thing that especially today, I worry that, a lot of the gains we made, we didn't make them just by medicine alone. We didn't make them just on our own efforts. We had help from the people in the community. Sometimes it was easy, sometimes it was hard, but it was critical. And now I worry a little bit about the advances we made. Look at PEPFAR, reauthorization, what's going to happen there, what's going to happen in the future. There's other challenges, and I think we can't think that HIV hasn't changed. If people can't access treatments, people are going to get sick. And I remember some of the slogans too from the early days. Remember, silence equals death, and I've been thinking lately, silence still equals death. So we have to use our voices and the voices of our patients, our community, people who care about this issue need to continue to be vocal. We need to appreciate where we are, and we need to sort of steadfastly keep moving forward and keep it, and bring more people along with us. We talked about. I used to think about, raising the bar, but I think it's sort of like, I don't want to raise the bar. I want to raise the roof. I want to have healthcare move forward for everybody. And so, yeah, we have to learn from the past, and we have to take the lessons of the past, and we have to honor the people who did all that work.
Yeah, yeah. I can't think of a better way to end the podcast. Kevin, thank you so much. This has been a brilliant uh, opportunity to recall the past and apply it to the future. And very grateful for you being with us today.
Well, I'm happy to be here, Mike. And also, I wanted to thank you for so many years of support.
Oh, my pleasure. All right. Well, we'll maybe do this again in the future, but this was just right. So thanks
Sure.
for joining us, Kevin.
Thanks. Take care.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.